everybody. Thank you so much for... Hi, everybody. Thank you so much for waiting. We were having some technical difficulties due to the coronavirus. No, I'm just kidding. But we did get everything fixed, and we do really appreciate you doing this from the computer instead of live due to the coronavirus, and just trying to be cautious and protect all of our employees and our patients and everybody. So we appreciate it. I'm Dr. Snow. I'm one of the OBGYNs at NorthBay Hospital. I work out of Fairfield and Vacaville. And today, bear with us because this is one of our first times doing this electronically. So if we run into some more mishaps, let us know if you're unable to get the stream or feed, and we'll do what we can to fix it as quickly as we can. And hopefully it will all go smoothly from here. So today we're going to talk about menopause, and that's a huge topic, but we're going to talk about a couple pieces of menopause. I entitled my topic on purpose, Dribbling, Drooping, and Drying Up. Proper ladies do speak of these things because they're common complaints I hear all the time. Almost everybody's going to experience some level of one of them at least, and not a lot of people want to talk about it. They're kind of quiet and behind the scenes, and it's something that we really want to get out into the forefront so that we can help people and they don't have to deal with these things on their own. I found this first slide on Facebook and had to put it in here because I found it hilarious. It's just the 7 witches of menopause: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. And it doesn't have much to do with the talk, but it's still hilarious because, I don't know, I'm going through all of those already and I'm not in menopause, so I'm not sure really what it has to hold for me. First topic is dribbling, and if you can't figure out what that means, it's not basketball. It has to do with urine and leakage of urine, as well as urgency and frequency and all the other things that can happen well before menopause but tend to get worse oftentimes after menopause. There's different types of urinary problems that can happen. Incontinence specifically is where you leak urine, and we'll go into more details about the different types of urine leakage that can exist. Overactive bladder is more of a concern when you have frequency or urgency. Your bladder is just kind of acting up and it feels like you have to go to the bathroom all the time, but maybe there's nothing there. It's very common. It affects millions of women of all ages, but generally worse as we age. And a big thing to know is it's not a normal part of aging. It's common. It affects up to 50% of women, but it's not something that you just have to say, oh, well, I have to deal with this. It's part of life. There's nothing I can do about it. We can't help. Symptoms of any urinary symptoms might be feeling like you always have to go use the restroom throughout the day, or even at night, getting up multiple times in the night because you have to go. Sometimes it's a lot of urine that comes out. Sometimes it's just a little bit, but it feels like you have to more. Leaking of urine without trying, that's the incontinence we were talking about, and just going to the bathroom throughout the day more than the average person would, 6 or so times a day. In types of incontinence, leakage specifically, stress incontinence is a type of leakage that is physiologic or physical. So as we get older and as the muscles get a little bit more weak, you don't support the urethra as much, and so it can kind of drop and have these little points where you cough or you laugh or you sneeze and a little bit of urine comes out. Urgency incontinence is different in that that's more of the bladder spasming when it's not supposed to, and sometimes that comes with leakage. Some people just feel the spasm and it makes them have to go, but they can still make it to the restroom, and other people leak urine without trying. Mixed incontinence would be leaking of urine that's kind of a little bit of both. Sometimes I feel the urge and I can't make it to the bathroom, especially when I get home and my hand's on the door. And I also leak a little bit when I cough and I sneeze. And so there can be a combination. Overflow incontinence, I threw it in here. It's not as common, happens more in patients with nerve disorders or accidents, but it's where the bladder fills up so much that it can't hold as much urine and you start to leak because of that, because you don't know you have to go to the restroom. Not quite as common as the other ones. I put this nice crazy slide in here just to give you a little idea of what's happening in your pelvic floor. I try to tell people to imagine as if I cut you in half and we're looking into the bowl of your pelvis. And as you can see, there's muscles here and there's ligaments, but that's it. There's no bones. There's nothing really that's holding everything together. And that makes sense because if you want to have children, you have to pass a baby through this area. So we can't have a lot of things obstructing the way. The problem with that is that as we age, this balloon full of muscles and ligaments stretches out. Pregnancies, other things we'll talk about that cause weakness in the area. And then we start to develop these problems as we get older. How do you know if you're having any of these symptoms? I mean, it's pretty obvious. If you cough or sneeze and you leak a decent amount of urine into your underwear, then you're having some problems. But sometimes it can be a little bit tough to figure out, is this something like a urinary infection and it's easy to fix? Is it more than that? So first thing, of course, talk to your healthcare provider, get some more information. Before you come in or after you come in, we'll often ask you to keep a voiding diary so that we can figure out if there's any particular things that are triggering the leakage of urine or the urgency or frequency. There are some minor tests that we can do in the office that come with very minimal discomfort, but overall everybody tolerates them well and they're easy to do. And then we do have more invasive testing that we can perform, urodynamic testing, where we can place catheters inside and really get a full measurement of what's happening with the urethra, the bladder, all over the place. We often don't have to get to that stage, but it is an option if we get there. But the first thing is just come and see someone, your primary care, your OBGYN, and we can start the conversation. Some of the things that you can do if you don't want to come see us or before you get to see us is to think about the amount of liquid that you're drinking. Sometimes it's as simple as, man, I didn't realize I was drinking 3 liters a day. That could be the reason that you're urinating a lot. Before you go to bed, especially, we tell people to limit the amount of urine fluids that you're taking in at least a couple hours before bed so that you don't have to get up as many times in the middle of the night. Certain foods can be irritating, especially if you have the urgency type of incontinence or you have the overactive frequency and urgency symptoms. The most common ones are all the good ones: chocolate, alcohol, caffeine, coffee, but there are other ones too: spicy foods, tomato-based foods, a lot of different things that can cause irritation. So if you keep those diaries, we can kind of figure out if there's something that's bothering you in particular. Weight loss can help in some situations, more for the stress incontinence, because again, the more pressure we have on that bowl of muscles, the more things are distorted and can leak. But it doesn't help everybody, so it's not a cure-all. Constipation is a problem long-term because every time you have to strain to have a bowel movement, you're weakening and pushing out those muscles. So a week of constipation is fine, but a lifelong issue with constipation is going to weaken those muscles. So we really want to minimize that long term. So if that's a problem for you, you'd want to talk to us about it. You can do that with increasing fiber, increasing water intake, although that might go against the bladder training problem. So you got to be careful with that. And of course, all the way up to medications and other things that are over the counter and prescribed that can help with constipation. And finally, if you are diabetic, making sure you have really tight control of your sugars is so helpful for a billion things, but definitely helpful for controlling urinary urgency and frequency and leakage. Other things that you can do if you're on certain medications that increase the amount of urine that you make or the urgency that you feel, sometimes we can change those to medications that don't cause that. So talk to your doctor, obviously, before you stop any medications cold turkey, but we may have better alternatives. There is a great product out on the market called Impressa, which is essentially just a tampon, but somebody's making more money off of it by giving it a fancy name. It goes in and supports the urethra vaginally by holding up the tissue and kind of gives you an extra support for that weakened tissue. So I tell people it can get really expensive if you were using this every single day. However, if it's an important event you're going to or something that you really want to make sure you don't leak, then this is a great choice to buy for intermittent use. Bladder retraining is something where we teach your bladder to not respond to the urgency that it's feeling. So in patients that have especially urgency and frequency, we want you to try extending the amount of time in between going to the bathroom. So if you're going every 30 minutes, you try to just do your best to not think about it and do everything you can to extend it to an hour. And then after you get control of that, you try to extend it to an hour and a half, and you just keep building up until maybe you don't have to go, but every 4 to 6 hours, which is a little bit more average. And then pelvic muscle exercises for the pelvic floor. And those are Kegels or Kegels. I've heard it called a billion things. I've always called it Kegels. Most people know what they are. We're going to go into it a little bit in detail, but they can be really helpful for rebuilding that support that's down there in your pelvic floor. For Kegels, this is a really basic set of slides that we're showing, and I'll go through it in more detail, but the first thing you want to do is make sure that you contract the pelvic muscles and lift them up. The second thing you'll do is hold the contraction, and there's a bunch of different guidelines. There's no exact science. I always say 10 by 10 by 10. So if you hold the contraction for 10 seconds and then release it and then contract again and hold for another 10 seconds and do that for 10 times a day, then that's definitely adequate. It might be overkill, but it's definitely more than adequate. After you release the contraction, you do want to give yourself a short rest, but you don't have to rest for 10 seconds or, that might take you all day. I've heard lots of different people talk about different ways to do Kegels, and I've heard trying to stop your urinary stream. So if you think about you're in the middle of going to the bathroom and somebody walks in and you need to stop it, that's one way to imagine contracting those pelvic muscles. I've heard other people describe, and my favorite one that was really funny was, imagine that you're sitting on a marble and you're trying to pick it up with your vagina. So I don't know if that works, but for some people that might work as a good technique to try to figure out how to get those muscles. If you get to the point where you just don't know if you're doing them right or they're not really seeming like they're helping, then that's where we can come in. We actually have people that can train you how to do what I call Kegels on steroids, or pelvic floor physical therapists. They will show you how to contract the muscles, even help you by placing fingers vaginally. A little strange, but it works, and showing you where to tighten and showing you if you're not doing it right. So it can be super useful. They also will show you other muscles around the pelvic floor that you might be able to work on to help support the pelvic floor. So there's a lot that goes into it. It's not just something that you can do on your own. Some people, it can help significantly more. If you're having urgency symptoms, or where you have that urgency incontinence, you feel like you have to go to the bathroom and you can't make it to the bathroom, or you just have to go all the time and it's frustrating. There are medicines that we can use that you take by mouth that can help with that. Come with some variable side effects for a lot of people, so it's not my favorite choice, but it does work well in some cases. Vaginal estrogen we can use to kind of plump up the tissue. It's not our first line, but it also may be successful in getting you some control back of your bladder. Pessaries are devices that go in vaginally and put support underneath the urethra. So again, if your urethra, especially with stress incontinence, you're coughing, you're sneezing, and when that happens, the floor bows down and you get this little drop in the urethra, these can support them, especially the ones that have these little incontinence knobs. They put a nice wheel in there and support the urethra and can help out. Acupuncture is something that I feel like every day we're learning something new that acupuncture can do, and this is one of the areas that's been studied, and we think that it's helpful. I haven't had a ton of patients try it, but I think it's always worth it. It's not medications, low side effect. I've done it myself for other conditions. I'm a fan. Botox injections, we don't do currently at NorthBay, but we can send you out to get those done, and can be very useful if you've tried other things. And even nerve stimulating implants that are placed in various areas of the body that kind of turn the nerve firing off and just tell it to ignore the fact that you're feeling that urgency can be useful. And finally, of course, there's surgical techniques. You've heard a lot of bad things about mesh. Of course, there's a lot going on in the media, and some of it's been pulled off of the market. That's different for this type of procedure. This type of procedure is a small piece of mesh that doesn't have the same complications, but we place it just like that little knob is going to go underneath the urethra. We place a permanent piece of mesh that goes underneath the urethra so that when you cough and sneeze, that urethra isn't allowed to bow down too much. Very successful. Of course, like anything, we want you to try other stuff before you get to surgery, but once you get there, a lot of people are really happy with it, and because it's such a minimally invasive procedure, it can be life-changing. Next topic is drooping. I got droopy there. If that isn't obvious, what I mean by that, I'm talking about things falling down. This only affects women because, again, we have that big open pelvic floor with no real support. The pelvic floor muscles over time, like we talked about, relax and fall and get stretched out. One of the things that can happen is your bladder can fall down. That's called a cystocele. Rectocele is where the rectum kind of pouches into the vaginal canal and can even start to come out through the vaginal opening. And then the uterine prolapse is where the uterus actually starts dropping down into the vaginal canal. And over time, in rare cases, it can come all the way out and even come outside of the body. This slide is, you've already seen it, just going back to that pelvic floor. The next slide is even more useful because it shows a little zoom in. So again, if you can't picture what exactly is going on here, try to imagine that I cut you in half and I'm looking at one half of your body now. Instead of looking at you from the top down, we're looking at you from the side. This is the uterus here, rectum over here, sacrum, back of the body, front of the body, the pubic bone. And this is the bladder here. So this is showing a cystocele when the bladder should be kind of staying right up here, but it starts to pouch in and fall down into the vagina and can actually fall down all the way to the opening. In part B, we're showing a rectocele. So this is the rectum or the intestinal end, and it's pouching into the vaginal canal and can actually push all the way and come out vaginally as well. And then on the final slide here, C, it's kind of hard to see because you almost need it to be like an animation, but the uterus they're showing is coming down. So all these supports that hold the uterus nice and high up here start to get weakened over time, and the whole uterus can fall down and come out. Things that increase this risk are, again, women. We're so lucky. We get the short end of the stick in a lot of medical things. So pregnancy, which is wonderful it is, and the fact that we can carry children, it destroys those ligaments. So just being pregnant alone can really be a risk factor. And then going on to have a vaginal birth can cause more problems with pelvic floor dysfunction and prolapse. Obesity can, again, with the more weight you have sitting on that pelvic floor, the more stretch that's going to be given to it. So weight loss can help. As we age, things get weak. I don't know about anybody else, but I'm certainly getting weak already. And things start to fall down. Long-term heavy lifting. So if you have people, they've done studies that are mechanics and using, really heavy equipment and going back and forth, they struggle with more prolapse. And funny enough, even labor and delivery nurses and us OBGYNs and other people that are in those rooms a lot pushing with your patients, you don't think about it, but you actually push with them. And so we have higher rates because we're constantly using those muscles when we're not supposed to be. I've actually tried to retrain my brain to do a Kegel every time I tell somebody to push. Works about half the time, so I'm not really sure. Some people have absolutely no symptoms from this, and that's fine. If you don't have symptoms, you don't need to do a thing about it. So don't worry about it. If you think something's there, but it's not bothering you, it's okay. Other people will feel a fullness or a pressure in the pelvic floor area, especially people describe it as getting worse throughout the day, or if you did a lot that day, a lot of heavy lifting, it's worse that day. Some people describe it as an achy feeling in the pelvis. Some people can feel a bulge coming out vaginally, so you can actually feel the bladder poking through, or the rectum kind of pushing out, or the uterus falling all the way down. Other people will have some urinary symptoms that come along with it. Incontinence is not uncommon, but on the opposite end of the spectrum, not being able to go to the restroom because of everything falling down and kind of kinking that outflow tract. So all of these things can be symptoms that you might experience. Obviously, the first thing you want to do, like everything, is see your healthcare provider if you're worried about it. If it's not bothering you, you don't need to see us. But if it's bothering you or you're concerned in any way, you want to come and see us. On exam, often we'll do an exam by looking with a speculum, kind of like a pap smear exam, and seeing what's falling down and where. We may even do a bimanual exam, that one hand in, one hand on top exam, to kind of see what's going on and where the weaknesses are. Things that you can do for yourself to help are Kegels. We've already talked about that. You may actually be able to reduce your chances of prolapse happening later in life if you are overweight and you lose weight. That can sometimes be successful. Getting treated for constipation, similar to all the other things with the urinary incontinence we were talking about, and avoiding activities that require you to lift heavy things repetitively. So yes, you can do it once in a while, but we're talking about daily 10 and 20 times a day, really heavy things, if that's possible within your job or your lifestyle. Things that we can do are, again, do absolutely nothing. We can just leave you alone. And that's actually my favorite thing to do when people come in and say, I felt this thing, what do I do with it? It's not bothering me at all. Say, you do nothing, we leave you alone. Try some Kegels at home if you want to make sure it doesn't get worse. If that's not working, we try pelvic floor physical therapy. We can help you to strengthen those muscles. Pessaries, again, same thing we already talked about. In this case, instead of just putting a little pressure on the urethra, we're actually using the whole device to really support the whole bladder, the rectum, the uterus from falling down. So they work really great, and they're non-invasive, no side effects for the most part, so people tolerate them. And none of that works, or you're just not interested in all that because it sounds like a lot of trouble, then surgery is definitely an option. Some of the surgeries that we do would be hysterectomy, so actually taking that uterus out if it's falling down. We can plicate or put the muscles back together and some of the strengthening tissue, the fascia that's underneath them, and lift up the vaginal wall anteriorly where the bladder sits. We can lower it down posteriorly where the rectum sits. We used to do this with mesh, and this is the mesh that has gone away. We don't do that anymore because we found out that it was causing trouble. It just wasn't a good place to mesh. It caused erosions and complications, infections. But still, we can use your own natural tissues or other things sometimes. There are a few other slightly more invasive techniques where we actually go into the belly and pull the tissues up and hike them up with meshes or without meshes. So we have lots of techniques that we can use to tack up all those tissues back to where they're supposed to be and try to keep them there with the stronger support system, not just the muscles and ligaments that aren't very good in most women. Final topic I want to go over is drying up. And I just put I don't know exactly what this is, but it kind of looked like the Sahara Desert to me. One of the things that is very common, this is probably the most common complaint that I get in my office surrounding menopause, either perimenopause or after menopause. It's caused by a drop in estrogen. So we all theoretically know that as you go through menopause, your ovaries start to slowly decline and they're not putting out as much estrogen. Estrogen is what keeps the vaginal tissue supple, it keeps it thick, it keeps it supported. The collagen that's underneath the vaginal epithelium is also supported by estrogen. So when that goes away, those tissues get atrophied or weakened. They don't have as much elasticity, and so that starts to cause problems, as you can imagine. Some of the symptoms that people describe to me are vaginal dryness, with or without intercourse. Sometimes just walking around through the day, it just feels like it's parched in that area. Other people describe a more severe symptom like burning and irritation. During intercourse, some people complain about less lubrication or having pain with intercourse because of friction that it can cause. And then vaginal discharge, that can be a sign of an infection in some cases, but a lot of times it's just the body's way of trying to kind of keep some moisture to that after the estrogen starts to decline. A lot of people are affected by this. Again, why I see so many people in the clinic with these complaints. 85% of women over the age of 40 years have some kind of dryness. So pretty much everybody is going to experience this if you're female. 29 to 59% report pain with intercourse, and that definitely seems right, probably closer to the 50%. So you're not alone. It happens to a lot of people. Up to 77% complaining of this vaginal irritation and discharge, and 50%, maybe less, maybe more, complain that their quality of life has been affected by this. And that's the most important thing. All the other stuff is kind of a natural part of going through this, but it's really how much it's affecting you, how much it's affecting your body, your relationship, and if you want to do something about it. Diagnosis is pretty simple. We talk to you, we bring you in, do a quick exam. If there's any concerns of an infection or something else going on, we might send swabs, but it's not a complicated visit that first time to talk about what's happening. Some things that you can do at home would be trying over-the-counter moisturizers. There's lots of stuff on the market. You can spend lots of money on this if you wanted to. I can't vouch for all of them. My favorite is buying a bottle of coconut oil, jar of it, keep it maybe separate from the coconut oil in the kitchen, but have it in your bathroom, and once a night you just take a little swab of coconut oil. Some people mix it with vitamin E. There's variable reports out there whether or not that's safe or effective, and then you take it on a finger and you place it vaginally. I describe to people, you moisturize your face twice a day. Why don't you moisturize your vagina twice a day? So once or twice a day, you just get some lubrication, and that can help significantly with some of the symptoms, especially dryness. During intercourse, coconut oil is fine, but it's not really that great. It's not going to last very long. And so I encourage people to explore other more commercial-based kind of things. There's water-based lubricants that are safe, oil-based that can be effective. My personal favorite are the silicone-based because, yes, they're synthetic, but they're just engineered to last longer. My favorite story about Uber Lube is that you get really weird stuff in the mail when you're a gynecologist. So I got like a sample of Uber Lube in the mail, and it's a brand, and I thought, well, let's see. So I just put a little bit on my hand, and I was watching TV, and wouldn't you know, like 45 minutes later, that stuff was not gone. I had to like turn it into lotion onto my hand because it wouldn't go away. So that's the thing that you want. You want something that's going to last long enough. And I swear I don't have stock in Uber Lube. It's just the one that I've seen out there that seems to be really effective. But there are lots of different brands that you can try so that you're not having the friction that is associated with irritation and pain during intercourse. Some things that we can do if you've tried that or you're not interested in trying those things is simply vaginal estrogen. And that comes in lots of different forms, tablets, creams, rings that you don't have to think about as often. The nice thing about the vaginal local estrogen is that it's not absorbed well into the body, and so it won't increase the levels at all or very minimally. A lot of people hormones got a bad rap at one point about being unsafe, and a lot of people come in and say, nope, I'm definitely not interested in hormones. And there's some validity to that when you're taking it by mouth or if you're taking it via the skin on patches. But the localized therapy to the vaginal canal is very low risk and has so many benefits. So it is something I'm a fan of if you've gotten to that point. Osphena is another medication that's newer, and the nice thing about that is it's a selective estrogen receptor modulator. So you take a pill by mouth and it acts there. So you don't have to kind of put things in that area, which can get a little messy and annoying after time. The bad thing about it is it's fairly new. It's not always covered. So it's a struggle with insurance. Interosa is also new and is slightly different form of hormone. It's actually DHEA, and so it takes your own natural estrogen that's in that area and converts it, and so you actually have more of your own local estrogen working in that area. It's great in the sense that it doesn't have any contraindications. So if somebody's had a previous history of breast cancer or blood clots and they're not a good estrogen or hormone candidate, they can use the Interosa DHEA. Bad thing, newer, insurance coverage, but we can work on it if it's something that we get to that point. Other things that are coming out, but they're not quite to the point where we're using them all the time, are vaginal laser therapy and other energy-based kind of devices. You place a probe in vaginally in the office, and for lack of describing it better, it drills these little microscopic holes into the vaginal tissue, and that causes the tissue to regenerate and thicken, relubricate. And so there's some good studies coming out showing that it may be very beneficial. As of right now, it doesn't have enough research, so it's not FDA approved. It's not endorsed by the College of OBGYN yet, but they did put out a committee opinion saying, we think it's probably safe. If you want to try it, we think it's probably safe. We just don't know enough about it. Because of it not being supported yet, it is not covered. It's nothing that we actually currently offer at NorthBay, but we certainly could refer you out to somebody that can do it in the local area if you're interested. Final thing I wanted to mention that goes along with the vaginal dryness is the sexual dysfunctions that come from that. And I put the slide up here because it's very complicated. So, I joke, and I don't want to make it out that men are simplistic by any means, but in my office, I joke that if the house was on fire, the man might say, well, do we have 15 seconds? Because we could do this. Females are different. We have a lot of things that are going through our minds at all times. So there's a lot of things that come into play, whether it's emotional or physical or psychological. And menopause is just one of those. So I don't want to pretend that there's a quick fix for anybody with sexual dysfunction. But when it's related to vaginal symptoms specifically, we have some things that we can do. The prevalence is pretty high. It's another common complaint that I get. Up to 15% women in their perimenopausal and early postmenopausal years. Tends to decrease as we get older, in that there's many theories for that, perhaps just less intercourse, interactions, other things that might come into play. We probably think that this is higher because people don't report this a lot. They're uncomfortable talking about it, or they just feel like, I don't want to deal with it. But those numbers are probably higher than we're seeing here. Some of the things that people experience, like we talked about earlier, are pain during intercourse, and that can be due to vaginal dryness or stenosis. The vaginal canal just kind of clamps down over time with that loss of estrogen and elasticity. Not wanting to have sex, and I always say that those two kind of go together in some cases, because who wants to do something that's painful? That sounds awful. So we got to first fix any kind of pain and discomfort issues, and then we can go on to address some of the other things that might be going on. If it's truly that there's no pain, there's no other issues happening, there are some things that we can still do to help people to want to have sex, to become aroused or excited more, especially in those perimenopausal and postmenopausal years, and to increase the chances of orgasm during sex, if that's something especially that's gone down as we age. Something that you can do, I I'm not sure that I wanted to put this in here because we just don't have a lot of good evidence that it's really effective, but it's very expensive. But this is the only FDA approved device that's out there, and it's a suction device that you can use on the clitoris to increase blood flow to that area. So very similar to devices that are out there for males in terms of increasing blood flow and suction to the area. But for the cost, I would definitely say check over the counter and look online. Amazon's got a great selection. There's a lot of other places out there that have a selection if it's something you don't want to do in person. But anything that can increase blood flow to the area with suctioning or vibration, those sorts of things can be very useful for any point in life, but definitely in the perimenopausal and postmenopausal years because of decreased blood flow, decreased sensation, and things that come along with it. You can buy really expensive stuff or really cheap stuff, and of course there's always something that's probably good for everybody in between. Vaginal dilators are not something that the majority of people would need to use, but in women that have been abstinent, not having intercourse for a while in their postmenopausal years, using vaginal dilators along with estrogen may help to get some elasticity back into that area. People that have had surgeries or radiation, other things, may consider vaginal dilators. It's something that we can prescribe and get covered most of the time, or you can buy them over the counter. There's not a ton of research about how to use them effectively as far as how long you're supposed to use them, how often, but I have seen success cases where they've been helpful. Some things that we can do other than what we've already talked about: hormones, getting the vaginal tissue back up to par, maybe even considering oral hormones in some cases, would be to try testosterone. And this is new. The College of OBGYN, ACOG, recently came out with this, saying that yes, we've done more research and we think that this is useful. For a long time, it was something that you only could get kind of on the black market. We recommend that you use testosterone transdermally because of the effects that can happen if you're taking too much of it. That's one of the best ways to absorb it. Postmenopausal women are indicated, and it may increase sexual interest and arousal. And we think it works because the ovaries also produce not just estrogen, but lots of other hormones, including testosterone. So as that level declines, that may be one of the main things that kind of gets that fire going for women. We recommend trying it 3 to 6 months first. If we're not getting any success after 6 months, it's probably not going to work. So let's call it a day because of the potential side effects. And we do want to do some testing with this because we want to keep you in the normal female range. We don't want you to get to male levels because that can cause some definite problems. Some of the effects that we see are things like hirsutism, which is increased hair growth, increase in acne. Virilization is less common, but it may be irreversible. So it's not something we want to joke about or take lightly. And that's where your voice can actually deepen to like a male level. You can get clitoral enlargement. So we gotta be cautious. And long-term safety on this yet, as far as breast cancer and other types of cancers, is pretty limited. So it's not the first-line therapy, but it's nice that we have this option because I've definitely had women in the past that have come to me from other places having been prescribed it or used it and found that it was beneficial. So I'm glad that ACOG supports it now. So that's the end of this talk. If you're interested in an appointment, we definitely can get you in and talk about any of these concerns. You can call our office. You can also send an email, and we listed it right here to get an appointment with us. Just wanted to throw up some references. And again, I don't have any stock in this, but it is one of my newest favorite books, The Vagina Bible by Dr. Jen Gunter. Just really goes into pretty much anything you ever wanted to know about your vagina and your vulva. It's in that book. So if you haven't had a chance to pick it up, I would encourage it. And this is my name and phone number if you're interested in making an appointment specifically with me, but we have lots of other providers that you're welcome to see. And final thing is, I just wanted to go over a few questions that were posted earlier from community members that were concerned. The first one was that I have an issue, but I'm not sure if it's considered incontinence. Can you please define incontinence? Hopefully we touched on that a little bit, but in case you missed it or just to review, incontinence is a broad term for leaking of urine. There's lots of different types of incontinence that can happen. Stress incontinence is the type where you cough, the most common one you hear about. You cough, you sneeze, you laugh hard, and you leak urine. If you have more of an urgency, like you go to put your hand on the door when you're at home and you don't make it to the bathroom, suddenly you start leaking, that's urgency incontinence. And then other more rare types like overflow incontinence that are less common. There's a spectrum. There are people that will have no incontinence but still have that urgency and frequency. They don't leak, but they just gotta go all the time. And so there are differences, but all of those are similar in the ways that we can treat them. And so we still encourage you to come in if it's something that's bothering you. Next question was, please discuss the advantages of using a pessary to eliminate leaking, also the pros of having surgery, such as sacrocolpopexy, which is awesome because that's a really specific question, so I'm impressed. The advantages of using a pessary, in my mind, is that it is relatively risk-free. We fit you in the office. Once it comes in, we make sure you're able to pull it in and out. We check on you a couple times to make sure it's not causing any problems, and then you're done. Most people are able to pull them in and out on their own. We do have patients that are more mobility limited, older, that we need to bring them in every 3 months or so and remove it. But most patients are able to manage this on their own, and we just check on them every once in a while. The best thing about it, I think, is that it's not surgery. So you don't have any complications of surgery. You have all these things that go along with that that are useful and so much lower risk. The bad things about it are you kind of have to think about it. We don't really want you to stick it in there and leave it in there for good and forget about it. So you kind of have to take it out. You have to clean it. You have to keep an eye on it. And some people just either aren't interested in that, or it sounds like too much work, or they're just not physically able to really consider it. One of the things as far as surgery, when we're talking about leaking of urine, it would be less common that we would do something like a sacrocolpopexy. That's going to be more for prolapse. Again, these may overlap a lot, but that's going to be more for things falling down, like the uterus falling down or the top of the vaginal canal protruding out. It would definitely be a more uncommon surgery. It's not something we jump straight to, but if you were having issues with leakage and prolapse, then that might be something that we would consider. It's a laparoscopic procedure, and we place mesh inside the body. Is different than vaginal mesh, very safe, and it tacks everything and holds it up. For surgery, other types of surgery for leakage, it's more of the transvaginal tapes or midurethral tapes, we call them. And those are those tiny pieces of mesh that we place underneath the urethra so that you're getting that support back from the urethra that's kind of bowing down when you're coughing and sneezing. Final question was, is it bad if I don't do anything and just ignore my menopause symptoms? And this is actually a question I get all the time. Absolutely not. So all of these, none of these things are going to harm you long-term for the most part. It's really quality of life. And I tell that to people all the time. If you don't want to do anything about it, you don't have to do a single thing. If you had a doctor that told you or provider that told you they saw something and you were scared of it, come in and have us check it out. But know that we might not do anything if you're not interested. But what we want to encourage is to open the conversation. We want to make sure people know that they don't have to live with these things if it is interfering with their life, and that there are many things that we can do, and a lot of them are very simple, effective, and not a lot of side effects and risks. So we have a ton of stuff that we can help you with if you're interested. And again, one more time, just in case, you can send us an email. You can call us at our main number, and they'll transfer you to the appointment line. And I hope you enjoyed the talk. Please let us know if there's anything we can do for you in the future.